To medicate or not to medicate, that is the question. We learned that symptoms usually lead to evaluation. We also know that evaluation typically leads to diagnosis, and that diagnosis in turn leads to treatment. And that's what we're going to talk about at this point. There are some myths about Prader-Willi syndrome that are believed by many psychiatrists, and I think it's because they've read selective pieces of information and they really have not seen enough numbers of patients to really render their own independent opinions. But many individuals believe that the eating behavior can be modified, and goodness knows people have tried for a very long time to use stimulant medications, all kinds of medications to modify the eating behavior, most recently some anticonvulsants. They believe that hoarding, skin picking, and getting stuck and perseverating are all OCD symptoms. And certainly we know that this is the case and that it has led to a particular treatment plan of medication therapy. And that that particular medication is an SSRI, which is a selective serotonin reuptake inhibitor. And many individuals believe that these medications are, quote, good for people with Prader-Willi syndrome, unquote. And I think we'll talk today about the fact that these are, in fact, myths, and hopefully our behavior as physicians will be modified so that we can serve our individuals better. The goals of psychiatric intervention are lofty, but we do really try to do this. We try to reverse medical, psychiatric, or behavioral deterioration. We want to restore the developmental trajectory of the child or adolescent, or restore the adult's ability to function at their level. We want to restore the support system or prevent the breakdown of an overwhelmed support system. This is really critical because we know how important the environment is to our individuals. And to develop a realistic maintenance plan to prevent the reoccurrence of the symptoms. Modifying the environment is very important. We heard Dr. Gurash talk this morning about the need to modify the environment and also to manage behavior. This afternoon we're going to talk about the coping aspects of the syndrome and also medication management strategies. This is a typical Prader-Willi syndrome individual under stress. They are not a happy person. We know that the environment can be modified. The individual's internal environment, or their ability or capacity to respond to the symptom or problem that they perceive, can be enhanced through what we call coaching. As we mentioned, individuals are not likely to be able to autonomously implement these procedures. But with cueing from individuals in the environment, they are able to do this with great success. There are 3 coping strategies that can be enhanced through this process. The first is cognitive problem solving. The second is using social support adaptively. And the third is using escape avoidance adaptively. The kinds of coping skills that we use for cognitive behavior solving are those that are largely designed to decrease anxiety, and they are relaxation techniques that do require sort of a rote learning. And as you could see from previous slides, this is a method that our individuals can assimilate and use quite productively. Deep breathing, guided imagery, and progressive muscle relaxation are all interventions that have been successfully tried and implemented in our population. And the benefit of this is that if it's in a home environment, then the parents have to be the ones to sort of coach the person through it, and vicariously the parents can perceive benefit from it as well. Anger management strategies have also been used, but they have to be very concrete, very literal, very scripted, and they also have to be developmentally appropriate. That means that an individual who is 13 but who is thinking more like a 6-year-old should have an intervention that is basically designed for a younger child but adapted so that they can implement it successfully. Social skills training is also an intervention that can sort of widen our individual's horizon and appreciate interactions with others more fully. We know that many of our folks are sociable and outgoing and they want to have relationships with others, but they really are unskilled at how to develop those, and once they are there, how to sustain them. One of the reasons is because of their egocentrism. Another is because the high degree of language difficulties that our folks possess. Unfortunately, there is a listener fatigue that goes along with it. And if you think of typically developing kids that are sort of picking up on things and responding very quickly, when our kids can't respond as quickly, can't put their thoughts into words as readily, they're not going to be as well received. And of course, if you're thinking of the right brain kinds of problems, that would be social communication difficulties, so that they're not good at reading between the lines. They're not going to be able to perceive jokes that other people think are funny, and they are most certainly not going to understand when they're the butt of the jokes, when they are being teased. We can teach them to register a complaint appropriately, and we certainly can teach them how to ask for help, and that is how to cue the environment that they are having a problem, so that the environment will respond to their needs better. Adaptive escape and avoidance can be, the example here is a self-initiated or prompted timeout, so that the individual can sort of cool down, have a cool down time, and then come back to the situation and resume the task. The use of these interventions never allows the person to completely escape and avoid the task. It only gives them a timeout so that they can reconsolidate and come back and finish what is expected of them. Another adaptive use of escape and avoidance that we all use is fantasy, and our folks are particularly skilled for using leisure skills. Their puzzle-solving abilities, their ability to do word searches, and other kinds of puzzle, self-directed and self-initiated puzzle activities are wonderful stress-relieving mechanisms for them, and they should be given opportunities to do them. Which brings us to the purpose for this lecture, which is about medication. Got meds? Announcing. Wouldn't it be nice to have a magic pill? Now, there are some guidelines of when using medications makes sense. And the very first and foremost is what I call eco-environmental or eco-behavioral interventions. First, you shape the environment. Then you shape the behavior, or you do behavioral interventions that are designed to manage the symptoms. If these are ineffective and the symptoms persist, that would be one indication for medications. If the psychiatrist believes that the medications are actually the result of an underlying disorder that has been unmasked by stress through all of the mechanisms that we just talked about, and that it truly does reflect another psychiatric disorder in addition to the Prader-Willi personality, then most certainly appropriate medications can be prescribed. For example, attention deficit disorder. We know from evidence-based source that stimulants are extremely effective with this disorder, and most certainly if our individuals with Prader-Willi syndrome present with all of the constellations of symptoms that are the criteria for ADHD, then treating with a stimulant is exactly the way to go. If the symptom is so severe that it results in a situation that produces danger to the individual or to other people, that is most certainly an indication for using medications. And the final is, if somebody is in a situation where their level of functioning is so compromised that their stability in that setting is compromised, I most certainly will use medications. And this, I think the perfect example of this is if an individual is functioning not well in a group home setting, and you're getting vibrations from the administration that this person's days in the group home setting are numbered, and if you have a belief that this is a good workable group home system and that there are very few other options available to the person, then stabilizing the system with a psychiatric medication until you can do all of the other things that you need to do, the environmental manipulations, the behavior management plan, the coping strategies, then that's a really good use of medication. And that same could be said for a school placement. Now we know that psychotropic medication treats underlying psychiatric disorder, manages selective symptoms, and by and large, across the board, alters an individual's threshold for response. And what that means is that there are parts of the brain that are basically gatekeepers. And if you can sort of raise the gate in the case of stimulants and attention deficit disorder, or lower the gate in terms of stress responses of all kinds, then you can help the individual sort of stabilize their internal environment, and it can lead to better behavior. So we look at the use of medications as basically providing a chemical buffer. So basically we now have a variety of different kinds of buffers. We have the environmental buffer that was described this morning. We have the coping buffer that we talked about earlier, and we have the chemical buffer. Now, before any medication is used, there are several things that should be provided to the parent or guardian of the individual. Informed consent is what it's called, and it involves describing the nature of the medication, the selected target symptoms for the medication, the desired effects, as well as the adverse effects. And those adverse effects should be further delineated into dose-related side effects. That is, the higher the dose, the higher the likelihood that a particular side effect will occur. Stimulant medications, for example, have associated increased pulse and palpitations and headaches, and clearly the higher the dose, the higher the likelihood that that will occur. There are also toxic reactions that can occur. Some people just have allergies to the medication, and very serious consequences might occur if the individual who is receiving the medication might develop an allergy. And then there are those allergic reactions as well as idiosyncratic reactions. And idiosyncratic means that if you read the physician's desk reference, it will say that in, say, 0.5% of the population of individuals who receive this medication, these things may occur. So they don't occur at a high enough frequency that you would sort of list them as side effects, but clearly they can happen, and if, unfortunately, you're the individual who's that 0.5%, then you've got a bad drug reaction. Toxicity, by the way, also refers to medications that are used at doses that exceed the desirable level for the individual, and we'll talk about that in just a minute. Informed consent also involves talking about drug interactions that can occur with medications. We'll talk about that in just a minute. Withdrawal symptoms, that's what happens if you stop a medication quickly without having the opportunity to taper it. There is a profound withdrawal syndrome that is associated with the immediate withdrawal of selective serotonin reuptake inhibitors, which is characterized by high rates of impulsivity, emotional lability, where you're sad, you're happy, you're impulsive, you're very anxious. And it can be quite a noxious experience for the individual and be quite stressful for the environment. Informed consent should involve the discussion of need for blood work, because some of these medications can be obtained through drug level by looking at the bloodstream, and we can gauge whether they're in a therapeutic range or not by what that level is. This is true of almost all the anticonvulsants as well as lithium. And also controlled access. At the national meeting in Ohio, we learned that, surprisingly, there is a fairly high rate of drug or medication overdose in children because they have accessed medications. If you think about it, it's just true of all kids. You know, they may see other people in the family take medications, and so they want to be just like the grown-ups, and so they do it too. So there is a need for controlled access to medications just like food. Now, medication efficacy, is it working? We define the target symptoms as I previously mentioned. We oftentimes use multiple medications, but the target symptoms are selected for that specific med. We titrate the dose. We start low and work up gradually. We don't start out at a large dose because our folks with Prader-Willi syndrome tend to respond to medications with greater sensitivity than the rest of us in the typical population. And then we want to assess the response. And we assess the response by getting some data. And the data can be obtained through checklists, rating scales. For example, the Connors or the CAP rating scale are excellent rating scales for looking at attention deficit disorder symptoms. Mood scales. There are mood scales that can look at whether someone is hugely depressed, moderately depressed, or sort of have a minor depression or dysthymia. Teacher report or journals are extremely helpful. Parent-reported journals are equally as important because I want to know not only what the teacher sees in a structured setting, but I want to know what the parent perceives at home in a lesser structured setting. And also, the physician should be reevaluating the efficacy of the medications on a regular basis. That does not mean once every quarter or once every 3 months. If you start a medication, you should see somebody back within a couple of weeks and perhaps in a month, and then perhaps if they're stable, then maybe quarterly. But as that medication is being titrated to its maximum dose, there has to be regular contact, either visually or by phone, and it's absolutely essential that this occurs. The medication log is something that all of you as parents can keep. This is extremely important. If you go to the psychiatrist and can present a medication log that basically has all of these items involved in it, the dates of medication dose changes, mood and behavior changes that you have noted, sleep and activity patterns that have been altered as a result of the medication, what your child or adolescent or adult has said about how they perceive the benefit of the medication, and also your impressions. This is hard data that helps us ascertain the benefit of medications. Now, a word about metabolism. It's a really big word, but it is so vitally important, and it's becoming more important the more we learn about psychotropic medications. And the questions that metabolism helps to answer are: how do meds get into the body? How do they get into the brain? How are they eliminated from the body? And what causes a drug interaction? Now, I want to have a little schematic here to sort of help understand how that works. First of all, most medications are ingested. A few are applied topically by patches. There's a medication called clonidine, or a medication called testosterone, or something like that, or some of the estrogen and progestin medications that can be put on to the body as a patch. And then the medication sort of is absorbed through the skin via the patch and gets into the bloodstream that way. Absorption is what happens after the medication is ingested. Okay, so what happens if you ingest it goes through the mouth, down the esophagus, into the stomach, and then it goes into the intestine. And the intestine is this very specialized organ that sort of absorbs all kinds of things, nutrients, food, medications, whatever. And from the intestine, it goes directly to the liver. And my analogy for understanding this process is sort of a visit to the amusement park. So basically, you go to the park, you come up to a ride that you really want to go on, you get in line, and you wait to get a seat on the ride. And then you experience the ride, and then you come back to a particular designated point where you disembark, and then you leave. And that's basically what happens to medications in the liver. There is this waiting line in the liver where the liver says, hello medication, how are you, and what do you need? And then it gets attached to specific proteins, and those proteins are like the cars that take you through the ride. And through that, then you go into the bloodstream with those proteins. And from the bloodstream, then it's a quick ride to the brain, which is the central attraction. And then from the brain, from the bloodstream, the medications are somehow taken across what's called a blood-brain barrier into your brain and into the nerve cell and gets right to the synapse. And that's where it all happens. That's where these medications have their remarkable effect. And then once they're used, they basically get repackaged up in a reverse fashion, enter the bloodstream, and basically make their way to the liver, where they are repackaged and processed, and then finally eliminated. Some medications are eliminated through the GI tract, and some are eliminated through the kidney. But basically, all medications run their course and they're eliminated. Now, where the problem occurs in metabolism is almost always in the liver. And the liver is very important, not only for this packaging process that we see, but also for the elimination process. So what can go wrong in the packaging is that some people don't have those proteins. So in other words, they don't have the cars that enable the individuals to get through the ride. And so what ends up happening is that the medication starts to back up. And when the medication backs up, it can become toxic. And then the person has a really big problem. These types of problems in the liver tend to be genetically determined. They are highly inheritable. And there are some tests, some fairly elaborate genetic tests that are now available to help us understand them. They also help us understand why drug interactions occur. Because if you have a medication aboard that is using up a lot of those CARs, or proteins, and then you introduce another medication that wants that same protein, then there's this little competition that goes on. And you can easily see why, if all of those CARs are utilized, the line's going to get long and the medication becomes toxic. So not only can you have drug interactions that lead to toxicity, but you can also have drug interactions that cause problems with the other drug that is added to the picture. And that's typically occurs with cough medicine. Cough medicine is a notorious medication for having an effect on these medications called serotonin reuptake inhibitors. Now, sometimes the opposite happens. Sometimes there are plenty of cars. It's like going to the amusement park on a rainy day. There are no lines and there are plenty of cars, and you get on and you can ride all day. And that's exactly what happens. Sometimes individuals have lots of these proteins in their liver or enzymes in their liver, and so the medication is just chewed up, packaged, and processed, and basically it never really does its thing. It can never get to the right level, and those individuals are called rapid metabolizers. And actually there's an equal probability in our population for having both slow metabolizers as well as rapid metabolizers. And so the response to the medication needs to be monitored very carefully by the physician, because these factors can have an extreme impact on how the person responds to the medication. Now, when we talk about pharmacotherapy, that is using medications for therapeutic purposes, this is my toolbox. I have these medications available to me: stimulants, anxiolytics, which are anti-anxiety medications, antidepressants, neuroleptics. Neuroleptics are medications that alter thinking, help with some extreme behavior like aggression and impulsivity, and also help those symptoms called delusions and hallucinations. Atypical neuroleptics, which are the ones that have been used fairly commonly now for treating severe impulse control problems and aggression, as well as symptoms of bipolar disorder, where you have both depression and mania, but you cycle in between those. And also the last is mood stabilizers. And those are the medications that are used for treating mood instability that presents as cycling disorders. And that's what we believe individuals with Prader-Willi have more frequently than in the typical population. I want to caution you that all medications have side effects. and to remember that psychiatric treatment is not just meds. There are no bad medications, only medications used badly. That side effects are more likely to occur in our population of individuals with Prader-Willi syndrome at standard doses, and I might add that toxic reactions are similarly more likely to occur, and that unfortunately to date there is no Prader-Willi pill, but we'll never stop hoping.